Hello everyone, my name is Mohammed Solomon. I'm a third-year internal medicine resident at the University of Arkansas for Medical Sciences in Fayetteville. And today I present to you an interesting clinical vignette titled Anti-MDA-5 Antibody Dermatomyositis in a Hispanic male post-COVID-19 infection. Idiopathic inflammatory myopathies are often characterized by muscle inflammation, proximal muscle weakness, and extramuscular manifestations. Anti-melanoma differentiation associated gene 5 antibody, or MDA5, is a unique myositis-specific antibody identified in 2005. MDA5 is a cytoplasmic sensor for viral RNA, and its expression has been associated with being induced by RNA viruses. MDA5 antibody dermatomyositis is a subtype of dermatomyositis that exhibits unique clinical features such as mucocutaneous ulceration, palmar papules, alopecia, paniculitis, arthritis, and interstitial lung disease. It's estimated that up to 80% of patients develop interstitial lung disease, and about 50% of those are rapidly progressive. Our case today is a 45-year-old male with no significant past medical history who presents with worsening shortness of breath. Of note, the patient had tested positive for COVID-19, however recovered with no residual symptoms. He presented with associated fatigue and recent 30-pound weight loss, and his wife had noticed discoloration and roughening of his fingers, shown here in Figure 1. Vitals on admission were significant for the patient, requiring 2 liters of supplemental oxygen saturating about 94%. His labs were notable for leukopenia, anemia, and elevated LDH. Imaging with chest x-ray and CTA showed infiltrates indicating multifocal pneumonia, and the patient was admitted for community-acquired pneumonia and was started on Rocephin and azithromycin. However, after a couple of days, there was no improvement in his symptoms, and a second CT of his chest was obtained, which showed worsening bilateral opacities here in Figure 2, indicating worsening multifocal pneumonia. At the time, a bronchoscopy was obtained with bronchoalveolar lavage, and further workup including a myositis panel, hepatitis panel, strep pneumonia antigen, pneumocystis PCR, and histoplasmosis antigen were obtained. The patient's pneumocystis PCR came back positive, as did the MDA5 antibody on his myositis panel. He was subsequently started on Bactrim and high-dose steroids, with improvement in his clinical course over the next several days. The patient was then discharged on supplemental oxygen up to 4 liters nasal. However, after a couple of days, the patient returned to the emergency department with worsening shortness of breath, heliotrope rash, V sign, and a fever of 104 degrees Fahrenheit. A CTA obtained in the emergency department showed similar findings to previous, indicating multifocal pneumonia. His labs were notable for hyponatremia, elevated liver enzymes, and at the time the patient was started on 20 liters of supplemental oxygen through a high-flow nasal cannula. With no improvement in his symptoms and the positive MDA5 antibody from his myositis panel, the patient was started on high-dose, post-dose steroids with Solumedrol IV 1 gram for 3 days and IVIG for 5 days after he was tested for IgA deficiency. The patient was also started on mycophenolate 500 milligrams twice daily, as well as prophylactic Bactrim for pneumocystis prophylaxis. A repeat CT chest was obtained after he completed the IVIG and post-dose steroids, and is shown here in Figure 3, which shows improvement in his bilateral opacities. The patient subsequently improved and was later discharged on home oxygen. Anti-MDA5 antibodies found here in this patient is often associated with a lack of muscle involvement in rapidly progressive interstitial lung disease with high morbidity and high mortality. Prompt recognition is critical in improving respiratory failure and slowing the progression of interstitial lung disease. Treatment of anti-MDA5 dermatomyositis includes steroids with a prolonged taper and glucocorticoid-sparing therapies such as azathioprine and methotrexate. Treatment of interstitial lung disease associated with dermatomyositis includes post-dose steroids and IVIG in severe disease, as well as agents such as methotrexate, mycophenolate, and cyclosporin. Opportunistic infections such as pneumocystis frequently complicate immunosuppressive therapy. In conclusion, anti-MDA5 antibody dermatomyositis is an uncommon yet emerging clinical entity characterized by rapidly progressive interstitial lung disease with high morbidity and high mortality. Prompt recognition of these diseases and treatment with corticosteroids and immunosuppressive therapy help to improve respiratory failure and slow progression of interstitial lung disease. Pneumocystis has been shown to complicate immunosuppressive therapy. However, in this case, the pneumocystis was identified prior to starting immunosuppressive therapy. Thank you for your time and have a great rest of your day.